Well, welcome to this presentation. I'm John Campbell, and I'd like to talk you through some of the causes of disease. Now, there is a separate presentation on the genetic causes of diseases. So what we're looking at here is the different environmental factors that can lead to disease in our patients and in ourselves. Because ideally, we want to prevent disease rather than treating it once it's come along.
In the healthy situation, the immune system exhibits what is described as immunological tolerance. This means the body, and the immune system in particular, doesn't generate immune and inflammatory reactions to any of the body's own tissues or to outside substances that should be immunologically tolerated, such as latex or nuts or shellfish. All these things should be tolerated. However, in hypersensitivity disorders, there's an exaggerated or inappropriate response to the body's own tissues or to outside agents which act as antigens. And an antigen, remember, is anything the immune system recognizes as being foreign. This means in people who suffer from hypersensitivity, there may be an immunological reaction to substances or indeed to the body's own tissues which should be immunologically tolerated. This is the essential nature of this form of abnormal immunity type disorder. Allergy is the common term used to describe one group of harmful effects generated by hypersensitivity reactions. And in allergies, there is an exaggerated inflammatory response to an environmental compound. An antigen which generates such an allergic reaction is termed an allergen. It begins allergies. And allergic responses and disorders seen in clinical practice include urticaria, allergic asthma, atopic dermatitis, allergic rhinitis, which we often call hay fever, allergic conjunctivitis. Very often we see swelling and there's redness, and very often in allergic disorders the lesions are very itchy as well. And allergies can be generated by foods, drugs, insect stings, different animals, and occasionally we see a very severe life-threatening form of allergic reaction, which includes peripheral vasodilation, hypotension, and sometimes bronchoconstriction in severe anaphylactic type reactions. So an anaphylactic reaction is a severe, life-threatening, acute allergic reaction. But beneath that, there is a whole spectrum of severity of allergic reactions that we do come across.
Now, the prevalence of peanut allergy in children in Western countries has doubled. In fact, it doubled between 2005 and 2015. And peanut allergy is becoming evident now in Africa and Asia. The question is, why is this happening? Now, the official guidance in the UK came out in 1998 that peanuts should be avoided in children who were considered at high risk of developing peanut allergy. But these recommendations were actually withdrawn in 2008. So what is the correct thing? Are we supposed to be giving children peanuts or not giving children peanuts? This question has been nicely answered in the New England Journal of Medicine in the LEAP study, LEAP, Learning Early About Peanut Allergy. Now, this study took a large number of children, 640 infants, who were at risk of peanut allergy. And they were at risk of peanut allergy because they had severe eczema or egg allergy. And these children were divided into two groups. One group was advised to avoid peanuts until 60 months of age, whereas others had peanuts introduced into their diet between 4 and 11 months of age. Obviously, we can't be giving young children with no teeth peanuts to eat, so it was obviously given as a paste type extract of peanuts. By the age of 60 months, it was found that 13.7% of the children who avoided peanuts had developed a peanut allergy. But of the children that were given peanuts at an early age, only 1.9% developed peanut allergy. And the difference was highly significant between the two groups. Now, this represents an 86.1% reduction in the prevalence of peanut allergies. So from 1998 until 2008, the clinical guidelines in the UK were actually giving contraindicated information. We now know that if we want to reduce peanut allergy, we need to introduce peanuts into children's diets at an early age. Avoiding it is the worst thing that we can do.
Another manifestation of hypersensitivity can be autoimmunity. Auto means self. The immune system is generating an immunological reaction against self, against the body's own tissues. So in health, the immune system protects against invading infections by reacting against foreign proteins. The immune system should recognize body tissues as part of the self and therefore should not attack them. But in autoimmune disease, there's a breakdown of this self, non-self recognition system. And this results in the immune system attacking the body's own proteins in tissues. In military terms, this would be described as an attack from friendly fire. In autoimmunity, the immune system reacts to some of the body's own tissues as if they were invading agents which needed to be eliminated. The immune system is making a mistake and attacking the very tissues it is supposed to defend. So, autoimmune diseases you might come across in clinical practice include diabetes type 1, Graves' disease, Addison's disease, pernicious anemia, Hashimoto's thyroiditis, and as illustrated in this picture, rheumatoid arthritis. Now this slide is representing diabetes mellitus type 1. So in the top left picture we can see one of the islets of Langerhans in the pancreas. Within that pancreatic islet there are beta cells, and the beta cells in diabetes mellitus type 1 are usually destroyed by autoimmune processes, where the body's own immune system systematically and very comprehensively eradicates the body's own beta cells, therefore eliminates the body's ability to produce insulin. And this is why diabetes mellitus type 1 is an insulin-dependent diabetes, meaning that the patient needs insulin injections in order to survive. But this condition can be well managed, and patients can now look forward with good management to many decades of reasonably healthy, or hopefully very healthy, productive life. Neo means new, and plasm in this context means tissue. So in a neoplasm, there is new tissue. And we divide neoplasms into two categories, benign and malignant. A benign neoplasm can grow locally, but will not spread systemically via the process of metastasis. A malignant neoplasm will grow and invade locally and may also metastasize to distant sites in the body, giving rise to systemic metastatic malignancy. So benign tumours do not metastasize, malignant tumours do have the capacity to metastasize.
This slide shows an example of a carcinogen and the type of malignant cancer it produces. And asbestosis is a complication of asbestos inhalation, where there is inflammatory and degenerative changes in the bronchial passages. But as well as that, asbestos can cause mesothelioma. And mesothelioma is a malignancy of the pleural membranes. And we can see on the left lung here that there's not that much left lung left, which is the dark area, but there is significant overgrowth of the pleural membranes, resulting in this large malignancy that we can see, the mesothelioma. And I don't know of any effective treatment for that. So we have to avoid the asbestos in the first place.
Well, in this picture we see a nasty tumour in a kidney. And one of the causes of renal tumours is smoking. So when people inhale smoke into the lungs, some of the carcinogens are absorbed through the alveolar membranes into the blood, where they circulate in the blood. And they're recognised as toxins. And one of the kidney's jobs, of course, is to filter out toxins. So the kidney filters out these toxins. But as it filters them out, it's going to concentrate them, meaning you end up with concentrated carcinogens from the smoke being concentrated in the kidney. And this is why smokers are more prone to kidney cancer. Well, quite a lot of epidemiological work has been done looking at the relationship between bowel cancer, colon cancer, and various forms of diet. So it's been known for quite a while now that people that eat a lot of red meat, lamb, pork and beef, do have a somewhat increased risk of developing colon cancer. And this is particularly the case if it's processed red meat. So people that are eating sausages, ham, salami, pate, tinned meats, these things increase the risk of bowel cancer more significantly than just ordinary red meat does if the red meat is processed. And it's been estimated that in Western countries, about a fifth of cases can be related to red meat consumption. Now, poultry, chicken and turkey and things, that probably doesn't increase the risk of bowel cancer. But burnt food does. Burnt meat or burnt fish. If it's burnt, you get chemicals called polycyclic hydrocarbons and aromatic amines, and these are believed to be carcinogenic. And actually, obesity itself is linked to colon cancer. People that have a high BMI above 25 actually have a 25% increased risk of bowel cancer compared to people that are at an ideal weight. So obesity itself, just through overeating, increases the risk of bowel cancer. And in fact, alcohol is somewhat linked to bowel cancer as well. It's estimated that about 11% of cases of colon cancer do have a fairly strong link with alcohol consumption. But I think it's important to remember that foods can be protective as well as cancer causing, as well as carcinogenic. So we know, for example, from large-scale epidemiological studies that fibre protects against bowel cancer. So fruit, vegetables, cereals, things that contain natural fibres, and particularly cereals and whole grains are protective against colon cancer. It's interesting to note why this is. It probably is because that plenty of fibre increases transit times, so the fecal material goes through the colon more quickly. And also fibre carries out some bile salts more quickly from the colon as well, which is a good idea. It's interesting, it's not really known for sure whether it's the fibre that protects against the colon cancer directly or other components of whole food, for example, flavonoids and folic acid. But it's probably not a good idea necessarily to take supplements. What it seems to be is a combination of these natural protective products like the flavonoids and the folic acid in combination with the fibre. So the best advice I can give you at the moment is not to eat too much red meat. Don't eat very much processed red meat at all. Don't burn your food products. Don't become obese. Don't drink too much alcohol. Do eat lots of fruit and vegetables, lots of green vegetables, lots of vegetables of all sorts. Cereals, all the things that contain fibre, but eat them in natural food products, natural whole food products. And those things will reduce your risk of bowel cancer quite significantly.
In addition to affecting tissues of the body where you get a hard tumour, malignant processes can also affect the blood. And the situation is much the same. We're getting a proliferation of out of control malignant cells. And in leukemia, the blood can almost appear white. That's what leukemia means. Leuke, white, emia, blood. And here we've got lots of malignant, useless monocytes in the blood. And this is chronic myelomonocytic leukemia, chronic myelomonocytic leukemia, with malignant monocytes proliferating and being found in the blood. Degenerative disorders are usually associated with older age, and they're sometimes described as wear and tear disorders, where there's just generalized wearing and accumulation of damage to body tissues and organ systems. And there can be accumulation of unwanted materials in the body as well. But it's important to realize that many people get to really quite significant ages with very functional physiological systems and functional anatomy. So we must never say that something is degenerative unless we can rule out some specific pathological cause and a specific disease process. Because often there is a specific disease process going on. It's just that this disease process is more common in older people. So always look for a particular disease process, because that may well be treatable. Well, we're looking at a normal brain on the right, and on the left, I think you can see that the cerebral ridges are much sharper. There has been degeneration of the gyri and enlargement of the sulci due to loss of cerebral mass, in this case caused by Alzheimer's disease. And Alzheimer's disease is one disease process in a range of dementias. And dementias describe progressive, irreversible losses of intellectual function. So dementia is progressive, it will always get worse. And if it is a genuine dementia, by definition, unfortunately, it will be irreversible. This diagrammatic slide also illustrates the loss of neurological tissue occurring in Alzheimer's disease. And on the right, we can see that there is loss of cerebral cortical material. But also on the right, we can see that the medulla has also been affected, with loss of medullary tissue showing itself in enlarged ventricles and shrinkage of other areas of the brain. And it is the loss of the brain mass that gives rise to the clinical features of this progressive, irreversible loss of intellectual function. Well, I think if you look at the hip joint on the left, you can see that there's a gap between the head of the femur and the cup of the acetabulum. It's not a very healthy looking gap, but there is one. And that gap will be filled by articular cartilage. But on the right, we can see that there's a loss of the articular cartilage and lots of very dense deposits in the area of that joint. And this is osteoarthritis, which is the most common type of joint disease that we see. It affects lots of people. And it can be thought of as a degenerative disorder from the biochemical breakdown of the articular cartilage in the synovial joints. And as well as degeneration of the cartilage, there's also degeneration of the subchondrial bone, that is the bone beneath the cartilage, and also of the synovium, the synovial membrane covering the joint that produces the synovial fluid. And this causes deep, achy, ongoing pain that's worse with use. Very painful, ongoing condition. Reduced movement, and eventually the joints can actually be creaky as bone grates on bone, the condition of crepitus, and the patients get very stiff and disabled. And it often is worse in joints that have been injured in the past. Well, here we're looking at a fairly typical presentation of osteoarthritis affecting the hands. And as we see, there is swelling in the distal interphalangeal joints. Here we're looking at the fairly typical presentation of osteoarthritis in the hand. And we can see that the distal interphalangeal joints are quite swollen. And indeed the proximal interphalangeal joints are also somewhat swollen. But this is the typical presentation of osteoarthritis of the hands. And the joints at the base of the thumb are also usually affected as well, although we can't see that on this photo. Heart failure can develop over time and present as a degenerative disease. And in heart failure, the cardiac function is insufficient to pump out enough blood to meet the metabolic demands of the tissues of the body. So the heart is failing to pump out enough blood to oxygenate the body adequately so that the body can metabolize to produce energy in all the tissues where it should be. But as well as that, if the heart is not pumping out adequate amounts of blood, this means that there's going to be a backlog of blood in the heart, and this can dam back into the venous system. And here we see that there's been systemic venous congestion, and that means that the tissue fluids are not being adequately reabsorbed back into the venous end of the capillaries due to increased pressure in the venous end of the capillaries, leaving too much fluid in the tissues. And of course, edema is accumulation of fluid in the tissues. And here we can see I've gently pressed my fingers into this patient's legs. Then when I've let go, it's left these indentations caused by the subcutaneous edema. Now, if the ability of the heart to contract has been reduced and it's no longer pumping out blood properly, then there's going to be a traffic jam of blood waiting to get back into the heart as well. And if there's a right ventricular failure, that means that the blood cannot get back in from the inferior and superior vena cava as quickly as it would like to. And if the superior vena cava is congested with blood, that means the blood from the jugular veins is not going to be able to freely drain back into the superior vena cava and right atrium. And here we see increased jugular venous pressure, secondary to right ventricular heart failure. Iatros is the Greek word for doctor. So an iatrogenic disorder is any disorder caused by medical treatments. And in fact, we normally describe iatrogenesis as any adverse effects generated by healthcare provision. It was Hippocrates who first said, "First do no harm." First do no harm. So sometimes we can't help our patients, but even then it's vital that we do no harm. So we need to practice with humility, because many of the things we do have got the ability to seriously harm our patients. And the worst thing that can happen is that a patient comes into our care and leaves our care
worse than they were in the first place. First, do no harm. And this guy getting his blood taken doesn't look very happy to me, so I think it's probably a bad idea. Now, for generations, leeches were used to take blood, and I guess they thought that by taking the blood out, they were letting out the badness and rebalancing the humours. Also, not a good idea usually. Although today, interestingly enough, leeches are being used again in certain specialist settings to evacuate hematomas.
Well, here we see data from the absolutely classic historical study of iatrogenesis. And we notice that in Vienna, in 1823, they started doing pathology. They started doing post-mortems in the morning. So the doctors would all go into the post-mortem room and do some post-mortems of the patients that died the day before. Then they would trot off into the maternity wards and they would do examinations, including PV, per vagina examinations. But they didn't see any need to wash their hands in between times because they didn't have any idea about the contagion of disease. Very hard for us to believe now, but doctors would do the post-mortems, and they had no rubber gloves in those days. They would do the post-mortems, and then they would carry out intimate examinations on pregnant women after that. Quite unbelievable, but it's not surprising they developed streptococcal puerperal fever afterwards. The puerperium, of course, being the 6 weeks after childbirth. And we notice that the data in the midwives ward, which is the darker blue line on the bottom, which of course midwives are justifiably proud of, that the incidence of puerperal fever remained relatively low because the midwives weren't doing these post-mortems and then transmitting the streptococcal and other bacterial forms onto their patients. And then of course Ingens Philipp Semmelweis, that famous medical pioneer, started introducing hand washing in solutions of chlorinated lime. And when he did that, when all doctors who were carrying out examinations before they examined the patient washed their hands in chlorinated lime solution, killing the bacteria, we see that the incidence of puerperal fever plummeted. So all that time there was all these iatrogenic deaths caused by the iatros, deaths caused by the doctor. We must always strive, whether you're a doctor, nurse or midwife or whoever you are, never to do any harm. Well, another unfortunately common cause of morbidity and indeed mortality in our patients is venothromboembolism. Veno means to do with the veins. Thrombus is a blood clot where that blood clot developed. And embolism is anything moving in the intravascular system. So in this case, if a bit of this blood clot broke off, it would go back up the veins into the inferior vena cava, into the right atrium, through the ventricle, and then will get stuck in some part of the pulmonary arterial system, causing a pulmonary embolism. So deep venous thrombosis can lead to pulmonary embolism when there is venothromboembolism. And this is particularly common in patients that have had surgery, especially lower limb surgery, but any form of surgery, patients that have had muscle relaxants, patients that have been on bed rest. In short, basically hospital patients become very prone to DVT and PE. So we need to make sure that we are taking all of the precautions necessary to prevent it. So that is early mobilization and keeping the patients as active as we can. If the patients can't get up, get them to move their legs in bed. If they can't move their legs in bed, we need to move their legs for them. And of course, we sometimes give drugs as well, anticoagulants that are going to reduce the probability of VTE occurring. Because make no mistake, this is a life-threatening iatrogenic pathology. So this poorly patient was nursed on their back for a few days, and during that time the weight of the body compressing against the bed surface, the weight of the body between the bones and the bed surface compressed the capillaries and occluded the blood supply, meaning the tissue has necrosed. So we don't want these pressure sores to develop in our patients. That's why we need to regularly turn them to relieve the pressure, and we need to monitor areas which are prone to pressure to make sure that no pressure areas are developing. Because once these have developed, they can take an awful long time to heal up. Well, here we see another sort of pressure sore on the patient's leg, but this was not caused by the weight of the body. It was caused by an improperly fitted thromboembolic deterrent, or TED, stocking. And we can see that the top of the stocking has caused a pressure ring around about the patient's leg, and on the front there the pressure has been sufficient to cut off the circulation and cause necrosis and ulceration of the tissue. This could have been prevented by evening out the pressure of the thromboembolic deterrent stocking over the whole surface, rather than let it get crumpled up and causing this area of localized pressure. Well, pneumonia is nearly always a bacterial infection, but people that are immobilized or people that are sick are more prone to developing pneumonia. Pneumonia being infection in the alveoli, in the parenchymal tissue of the lung. And patients are also more prone to developing pneumonia if they're nursed lying flat. So patients should be nursed sitting up wherever possible. And I think you can see here that there's consolidation in the right lung caused by pneumonia. Well, all drugs can have side effects. Steroids, for example, the longer the patient is on steroids and the higher the doses, the worse the side effects are going to be. And there's a range of possible side effects that can happen. For example, here we see the buffalo hump caused by the accumulation of adipose tissue in the back. And we see the thinning of the bone caused by steroid-induced osteoporosis. So whatever drug we're giving, we need to know the effect of that drug. So we're going to look out for the effect of the drug, but we need to know the possible side effects of that drug, both in terms of the acute side effects, such as severe allergic reactions that might develop, or the more insidious side effects that can develop over time as the drug is administered for longer periods of time. Well, my congratulations if you've got this far in the presentation. We've looked at many different exogenous causes of disease: mechanical causes, chemical causes, malnutrition, biological causes, infections, vascular causes, allergies and hypersensitivities as causes of diseases, autoimmunity, neoplasm, degenerative diseases, psychiatric disorders, psychosomatic disorders. And these are all true, but of course many diseases are multifactorial in etiology, which complicates the issue somewhat. They have many different possible causes, interacting genetic and interacting ranges of environmental factors. But whenever you can work out what's causing a disease, that gives you the power to start preventing it, thereby promoting the health of the people that you're working with. Now, this last slide is about idiopathic disease. And idiopathic basically means we don't know what has caused it. Unknown pathogenesis, or apparently a spontaneous condition. Now, sometimes the term essential is used. For example, we might talk about essential hypertension. And I guess that means much the same thing as idiopathic. So it's a primary disease. It's not caused by anything apparent. It's not a secondary thing. It just seems to arise. Spontaneous, idiopathic, primary pathology. But hopefully, as time goes on and we learn more about the etiology of disease, the number of diseases which are idiopathic will reduce